start right off with our first speaker. Let me introduce Giacomo Pavesi. Go ahead, Giacomo. Please introduce yourself and go on with your presentation. And welcome.
Thank you very much. We are speaking from Italy, in Modena, which is a town in the middle of Italy, and it's a very nice day with sunshine. You can see the light coming from the window, and we are very glad to participate in this webinar, and very thankful to Professor Cato, who invited us to speak about cerebral aneurysm. And I think we can move to the presentation.
Okay.
Okay. So we are going to talk about the treatment of unruptured aneurysm and about the middle cerebral aneurysm in particular, because the question is if they are always a microsurgical matter. I mean, if they have to be treated by microsurgery alone and not endovascular means. So what is the question and what is the answer? Of course, middle cerebral aneurysm are frequently a microsurgical matter, but not always. And this is why they are so various in morphology and in location along the middle cerebral artery. So they are a very various type of aneurysm, very different one from another. And of course, the prevalence of intracranial aneurysm is much bigger than the number of aneurysms that rupture. And we know that 1 year mean risk of aneurysm rupture is rather low, especially for small aneurysm. And we have to look at the risk of their preventive repair, either surgical or endovascular, because we have to balance it with the risk of rupture. And many prognostic factors for aneurysm rupture have been proposed, and we have some guidelines that aim to size, location, morphology, or documented growth of the aneurysm, and the patient-related factor as age, history of previous SAH, or family history, the presence of other aneurysm, and conditions that predispose to higher risk of hemorrhage. So we have some prognostic factors that may lead us in the choice of treatment. And Pavesi scores have been developed for the prediction of risk of rupture, and this entails some important factors like hypertension, age, the size of aneurysm, of course, and the presence of other hemorrhage before and the site of the aneurysm. And the guidelines are not so clear-cut, and we can reach a conclusion that it may be reasonable to choose endovascular therapy for a selected unruptured aneurysm when surgical mobility is high, and this is for basilar apex or elderly patients. In the other cases, the option of surgery or endovascular is not so clear. MCA aneurysm are a very frequent one, and they are about 40% of all intracranial aneurysm. They have a peripheral location, which is very superficial to the cortex. So, and the wide neck incorporates the origin of one or both M2 segments. These are the reasons for because they are so considered a surgical matter. For this configuration, they largely remained in the domain of surgery. However, endovascular therapy is still increasing in indication and in options, also in MCA aneurysm. And there are a lot of series that have been published in aneurysm of the middle cerebral artery, that shows that surgery is very, very successful with a very low morbidity risk of procedure. This is because now we approach these aneurysms with a very, very small and targeted approach, which entails just a very few millimeters opening of the sylvian fissure, and a safe clipping can be made without a very big surgical exposure. This is for unruptured and small aneurysm, of course. We went through our caseload of unruptured aneurysm, and we saw that MCA aneurysms are the most frequent ones, and besides, they are also the most frequently associated with morbidity. So it is true that they are easily accessible, but it is true also the contrary, that they are not so easy to clip without damage. In our series, they were the most commonly associated with morbidity, MCA aneurysms. So they are very risky. It's a very risky location, actually. And open microsurgery, from what comes from the literature, should be considered as primary treatment due to its high occlusion rates and low complication rates. And endovascular therapy should be administered in elderly patients or significantly calcified aneurysm wall, or when the aneurysm geometry is more favorable for endovascular rather than surgery. And a meta-analysis that has been published in 2018 in Neurosurgery confirms that MCA surgery continues to be a safe choice, even if endovascular has lower rates of occlusion, we can conclude. Which are the main surgical complications I was telling you before? They are entailing perforatory injury, which is the most risky, arterial branch occlusion, damage to the venous system, or brain contusion during dissection. Of course, we have means to improve our results, and they come from technologies like flow probes, intraoperative flow Doppler, indocyanine green angiography during surgery, intraoperative digital superfraction angiography, which is available if you have an hybrid operative room like we have the luck to have, and motor evoked potential in some selected cases may be very, very useful. So these are the means of technology that now we have to have when we give indication for these operations. And in our series, we have 51 unruptured MCA aneurysm. And so we went through some cases to show the difficulties we have encountered and the problems that you may meet during these cases. The case one is a male, 64 years old, who presented with transient left hemiparesis and aphasia. And he had two unruptured aneurysms, one partially thrombosed right MCA bifurcation, one right ICA bifurcation. What to do? In these cases, you can see the CT with MCA partially thrombosed aneurysm, and then the reconstruction of 3D angio-CT, DSA to complete the diagnosis, and the patient was brought to surgery. And we look at this illustration depicting the thrombosed part of the aneurysm and the active part of the aneurysm on the MCA. And this is the post-op control. This was a very successful cases for surgery. And case 2, female, familiarity for unruptured aneurysm, transient amnesia, CT scan, multiple aneurysm. And you can see these are incidental diagnosis of cerebral aneurysms, multiples. The choice is very difficult, but in this case we approached the MCA aneurysm on the left, and it was treated because it was very favorable to do it. And you can see the angio control intraoperative, and the postoperative course was fine, and the other aneurysm on the perical lobes will prefer to and go to endovascular, not to have a second craniotomy. And for what concerns the right MCA aneurysm, I think we will offer the patient a second surgery on that side. That's how we think about it. Case 3, male, 72 years old, family history of subarachnoid hemorrhage, hypertension, incidentally discovered left MCA after a head trauma. You can see the aneurysm is not big, it's broad-based. It is considered a very low risk of hemorrhage aneurysm, but she has some risk factor that considered. Generally, we went to decide for surgery. She had a transient aphasia, maybe linked to the manipulation of the temporal lobe, and good recovery very soon. But after 3 months, she had a partial seizure, and she came with this CT with a subdural chronic hematoma that was treated conservatively, and 6 months later it disappeared. So we have to follow up these patients for a long time. And this case is 80 years old, male. He had a first operation on 1994, clipping for an MCA aneurysm. At 2004, the CT scan was negative. And then he had a syncopal episode. Clinical examination was negative. And in 2012, he came with a CT that showed a large aneurysm at the MCA bifurcation. And this is the case, and this is very interesting because it was clipped a long time before, and it was very good clipping, but in the years, these aneurysms regrowth, and you can see the regrowth of the aneurysm at 18 years from surgery. The aneurysm regrowth on a weak side of the clipping, and this is the DSA. And this was a very complex operation. This is an illustration of what we have found and how we treated this remodeling of the new aneurysm. And this is the postoperative CT scan. He had a transient left hemiparesis that solved after a few weeks. Female, 33 years old. She had a subarachnoid hemorrhage in 2013. She had an operation elsewhere, and 5 months later, she came to us with an acute headache, and the CT scan and DSA showed a residual aneurysm. What to do? This is very interesting because it's a redo operation on an elsewhere than clipping. Partial clipping, as you can see, and it's very difficult to make decisions about this because these are very risky. But if you look carefully at the angiogram, you can see that the aneurysm filling from an anterior temporal artery that goes straight inside the aneurysm. So we decided together with the endovascular fellows to coil this temporal artery and exclude the aneurysm without damaging the flow on the MCA artery. So this is the final result of occluding with a little bit of coil the sac, and this is the post-operative course. And she had an uneventful recovery. And this case it's another different kind of MCA aneurysm, left hemiparesis, intermittent headache, and psychomotor impairment. She had a giant serpentine MCA, partially thrombosed. What to do? This is the case. This is a very big thrombosed serpentine giant aneurysm, and you can see calcified walls, and the involvement of both temporal and frontal artery from the MCA. So what we have done is a partial embolization in order to reduce the flow inside the sac, and then go for surgery directly the day after. And this is what we found. This is another illustration. You can see the big aneurysm, the M2 temporal artery and the M2 frontal artery coming from the base of the sac of this giant aneurysm. So we cut the branches and made an anastomosis between M1 and M2, while the M2 flow was considered intraoperatively with indocyanine sufficient to irrorate the brain. And this is the DSA post-operatively. You can see a small clip where we closed the outflow of the frontal branch and the reconstruction of M1 and M2. The pointer is on the side where we made the anastomosis. She had a left hemiparesis and frontoinsular ischemic area that we couldn't prevent totally, but I think that with the anastomosis we prevented a large brain infarction that would have her to suffer for all the hemisphere. So at 1.5 years, she has this ischemic area, but she is improving. She can walk. Of course, she has a slight hemiparesis. And case 7 is 73 years old with anticoagulation therapy and transitory right neurofascial dysarthria, incidental MCA with percussion aneurysm. What to do? This is a case that is very impressed in our mind, because there's a small aneurysm, 73 years old, and of course, guidelines says that maybe it's not that at risk. The only associated factor was anticoagulation therapy and hypertension. And this aneurysm is not so easy for a surgery, because you can see almost the fusion of one branch on the side of the sac. And this is what happened during surgery. She had a hemorrhage on the base of the neck of the aneurysm, and during clipping maneuver we had to sacrifice a perforator. So she had this after surgery, this CT, and she developed a left hemiplegia because of ischemic injury on this perforator with the ischemic area that you can see on the 2-day CT scan. So this is follow-up at years, but she remained with a very severe deficit. So these are scary malformations, and they carry an intrinsic risk of damaging if surgery has some peri-procedural trouble. So they are not so, they have to be looked very carefully and to consider the risk of treatment. We thank you very much from Italy, and see you soon.